I thank Wincars for organizing this conference in such a grand and beautiful way. And my greetings to the esteemed faculty on stage. Yes, I'm Dr. Chetana from Jayadeva Institute of Cardiology. Story of a complicated left main bifurcation stenting. It all began in December 2022. A 56-year-old gentleman presented with anti-wall MI. He was taken up for angiogram at an outside hospital. His RCA and LCX were normal. LAD was showing a thrombotic lesion extending from the ostial LAD to the mid LAD. He was taken up for primary angioplasty. He was stented with a stent of 4 into 38 mm from LM into LAD. And after stenting, they noticed a pinching of the LCX, and hence LCX was wired and the stent was deployed in the LCX 3.5 into 24 mm NeoFlex stent. So we actually see an underexpanded stent at the LCX ostium there. So what happened 1 year later was that the patient came to us with complaints of effort angina, CCS class 3 for the last 2 months. So since we had seen the CD of the first procedure and we did find an underexpanded stent in the LCX ostium, with anticipating a complication there, we did an angiogram. And as expected, there was a serious ISR at the left main bifurcation, a significant ISR at the LCX ostium. We could see the crushed and the unexpanded stent struts at the LCX ostium protruding into the left main, although the LAD was flowing quite well. So we gave the option of CABG to the patient at that point of time. Since the patient and the relatives refused, we were left with the option of angioplasty. But what do we do now? Which wire would cross that crushed and distorted segment of the LCX stent at the ostium there? And would we go with an upfront two-stent strategy or a provisional stenting? So to answer all these questions and to ease us, we decided to go ahead with angioplasty under OCT guidance. So via the right femoral axis, we cannulated the left main with a 7 French EBU catheter. And we wired the LAD with a run-through wire, parked it there. And as expected, there was difficulty cross the wire into the LCX through the distorted and crushed stent struts. So we started with the Fielder FC wire into the LCX. We were not successful, and then we went ahead with Fielder XT. We frantically searched for all the wires we had in the cath lab that day. And finally, we could cross it with the Gaia 2. So next, as planned, we went ahead with an OCT run of LAD as well as LCX. So the pullback from LAD, what was the information that we wanted? One, left main size. Was it also deceased? If yes, what was the morphology? Is the LAD stent expanded well? If not, what's the reason? Was there an ISR of LAD stent also? And is the LAD stent fully covering LAD ostium? So this was an OCT run of the LAD. Not sure if it's the playing. However, I have the still images of the OCT run of the LAD. The distal part of the LAD had a good stent expansion and apposition. The MSE was 8.5 mm square. So as we came towards the ostium, around 10 mm from the ostium, there was under expansion. No neointima. There was 180 degrees of calcium there. At the ostium, we could see under expansion, calcium from 11 o'clock to 3 o'clock position, and mild neointima. So the reference vessel diameter was 4 mm. And we also noted down that 15 mm of the proximal LAD needed to be further expanded. And we also noticed that the LAD stent was extending 7 mm into the left main. And the left main was a 5 mm vessel with fibrotic lesion. At the conference, we had observed underexpanded stent with a lumen diameter of just 2.7 mm with stent struts of the LCX protruding into the lumen. Next, we proceeded with the OCT run of the LCX. So we wanted to know the MLA at the diseased area beyond the stent, whether we needed to cover it this time. Was the LCX stent distally well expanded? What happened to the ostium? What was the morphology of the vessel there, and what about the struts there? So after we did the OCT of the LCX, the information we got was that the lesion beyond the stent, there was a fibrotic and calcified lesion there. And distal part of the stent, at least most of the stent of the LCX had no neointima, had a good MSA. Only at the ostium, as we scroll back from LCX to LM, so we noticed that there was under expansion, there was calcium at 11 o'clock and at 6 o'clock, and crowding of stent struts at the left main and neointima. So we decided to keep it simple. We decided to do a BOBA to the LAD and stent left main to LCX. So we did a high pressure balloon dilatation of proximal LAD with 4 into 10 mm NC balloon, followed by left main to LCX stenting with a 3.5 into 23 mm drug eluting stent. So following this, we recrossed the wire into the LAD and we post dilated the stent, and we did a kissing balloon with 4 into 10 mm NC in LAD and 3.5 into 10 mm NC in LCX. And we did a pot with 5 into 8 mm NC balloon at 10 atmospheres. So post-procedure, we took the OCT runs of the LAD and LCX again. So we noticed that there was a good MSA of LAD and LM. There was no dissection, there was good stent apposition, there was good stent expansion, good stent, the bifurcation looked good. So this was the run from the LCX to the LM. There was a fully expanded LCX ostium now. There was no malopposition, no overcrowding of stents, no under expansion. So finally, we could give a happy ending to this patient. I'm not sure. I'm sorry, the video is not playing. Yeah, there was a good flow in both LAD and LCX. And what we wanted to highlight is the message of the whole case was that usefulness of imaging in evaluating and optimizing results in stent failure is immense. Thank you.
Came with the restenosis to you?
Yes, yes. After almost 1 year after the index procedure.
So he came directly with the second episode of angina to
Correct.
you?
For 2 months, he was having effort angina, almost class 3. And he had just got the CD of the first procedure where not all the shoots were there and many of the steps were missing. Like we didn't know exactly what was the bifurcation technique they had used, whether they had really recrossed the stent and gone into the LCX, or was the stents side by side and they got crushed by each other. It was not clear.
Okay. What do you think the first step of LAD stenting went wrong? The sizing of the stent was correct?
The sizing, the distal LAD, the MSA was quite good when we did the OCT, but I think they had protruded into the left main, almost 7 mm into the left main, and they could have done a pot, but
You kept telling it was under-expanded stent.
The LCX stent was like under-expanded, ma'am. The
Even
proximal part of the LCX stent.
Ostial LAD, don't you think it was not properly
correct.
post-dilated? And
Yes, ma'am. Yes.
So the recrossing was done with which wire?
The first
LAD.
procedure?
No, the LCX, which the ostium was
The second
totally
time when we did, we crossed with Gaia 2.
Gaia 2. And did you stent the second time?
We did LM to LCX stenting. We didn't stent the LAD. We just did a post-dilatation of the LAD with an NC balloon.
So the stent was there in the LAD ostium?
Yes.
The
Ostium was fully covered. But there was under expansion. We noted there was a calcium arc, 180 degrees calcium arc there. So that was probably why it had not expanded fully in the first time.
So the second time, did you use any cutting balloon or anything?
No, ma'am. This time we didn't have the size of the balloon. We also wanted to use a drug-coated balloon there, but we didn't have the size on that day.
Did you, you are telling it was 180 degree arch.
Yes.
And did you plan using IVL or something to just break open and then re-expand?
Yeah, IVL would have been a good choice, the calcium modification, but the cost was another factor.
Under the manifestation. Yes, it was a good case.
But after post-dilatation, the OCT run shows there was sufficient MSA and good MSA there.
Okay.
Actually, if you see the first stent, LAD stenting,
Yes, ma'am.
it's oversized. First thing is, see, it's not. I think 4 you told, 4 size.
Yes.
So if you match with the mid LAD, it's not 4, and they have not done pot also.
Correct.
So that is the main thing. The second thing is they did not check for any carina shift. I
Correct.
don't know what they have done.
It was a
You
second
don't
tier
know.
city where they have just rushed in for a primary angioplasty.
See, 1 to 2 struts they can leave in LM. Suppose in all cases it's not possible to do LM stunting, then but they have to do pot. That they have
Yes.
not done. Second thing is, did you ask for any discontinuation of the medication?
No, there was
Was
no
he on ticagrelor?
No, he was on medications, ma'am. He was on ticagrelor
Medication
and
only.
aspirin. Yeah.
So
that was not an
the
issue.
second thing, the second point is he is not under regular follow-up at the primary, doctor who has
He
done that.
did go there, but he was sent on medications twice. So with
Okay.
that persistent symptoms, he came to Bangalore.
So I think the problem is the oversizing of the LAD stent, and they have not done pot. That is the reason there is a carina shift, which has resulted in the L6 ostial stenosis and lesion. So another thing is it necessary? That means you had to use that Gaia wire. It's not going. Otherwise, they are not going to
We
the
used
L6
almost
because
4 or 5 different wires. And then
Okay.
frantically, we just tried every wire that was available and Gaia took
okay.
it.
So the L6 stenting, it's good. The end result was good. Where did you the proximal LMCA? Did you do pot again?
Yes, we did pot with a 5 into 8 mm NC balloon.
Okay, okay.
Yes.
So the final result was good. So you have to educate the patient
Yes.
and about the. It is lucky he has come to the your institution. Otherwise, patient can have sudden cardiac arrest if
Correct.
there is a thrombus that forms in the L6 ostium. So the learning points is we should always size the stent depending on the distal part of the lesion, and then you have to do pot. Second thing is you should not see if there is any IVUS or anything is there. A carina shift, how it is there, that you have to do. Otherwise, also if you have a doubt, you can do a balloon, kissing balloon,
Yes,
is it not?
Yes, ma'am.
So, okay, thank you, good case.
Okay. Thank you.
Thank you, Dr. Chetana.